Hi, welcome everyone. This is Kate Scarlotta. We're going to be starting in just a few moments. We have the pleasure of having Ann Lee with us today, or this evening almost, yes, talking about celiac disease in the era of COVID-19. We'll wait another minute until everyone gets in and gets settled. Oh, didn't mean to do that. Okay. Again, this is Kate Scarlotta. I'm the VP of Nutrition and Translational Science at Epicured, and I'm very excited to listen in to Dr. Ann Lee talk about celiac disease in the era of COVID-19. To get started, I'd love to just do a little intro about Epicured. We are a healthcare company that delivers delicious, freshly prepared, gluten-free and low FODMAP foods. And we have a number of partners that we work with, including Dr. Bill Che and Tony Lembo, who we are actively in the process of doing research with, a number of medical centers, including Mount Sinai, and a number of independent practices, as well as patient advocacy groups such as Crohn's and Colitis Foundation, IFFGD, and the National Celiac Disease Center or Association. So Epicure's first menu has been focused on digestive health. It is a low FODMAP and gluten-free menu, so designed to help individuals with irritable bowel syndrome, IBD, and small intestinal bacterial overgrowth, as well as gluten-free for those who have celiac disease or non-celiac gluten sensitivity. We think of the menu as Mediterranean with a twist. There's lots of plant-based offerings, and our menu has really a lot of wholesome, delicious food. As you may or may not be aware, the low FODMAP diet is a pretty complicated diet to roll out, lots of nuances with its application, but it does work. In fact, up to 86% of people with IBS have noted symptom relief with a low FODMAP diet. So Epicured really works to translate the research into providing delicious food for patients requiring prescriptive diet. And how we like to think of some of the benefits for you using Epicured and your patients, it can really be leveraged as a diagnostic tool. Trying a few days of a low FODMAP diet can really help an individual understand if they have FODMAP sensitivities or not. Perhaps before you delve into the depth of the education, you could try a low FODMAP diet. It also is wonderful to receive food that's freshly prepared and minimize the stress of applying the diet, which can be complicated, but also, provide foods that we know will be effective for those that are FODMAP sensitive. So it really takes out the guesswork. Patients can also relax and let the cooking be done by us and let the diet work for them in really soothing their digestive symptoms. And probably one of my, of course, as a dietitian, what I really enjoy about Epicured is just the wide variety, 70 menu items that really can help patients increase their plants and fiber intake and really eat a well-balanced diet. If you are not a Partners in Health clinician or part of our Partners in Health network, I highly recommend this program, and we will be sending a link to you after this clinical webinar. There's a wonderful resource portal with a number of webinars that you can utilize to get credits from CDR. We also offer free brochures and educational cheat sheets, prescription pads where you can offer clinical discounts for our foods, and also an opportunity to provide guest blog posts, or we can share your information via social. Oh, sorry about that, too quick. So how does Epicured make you feel? This is no kidding, you were a lifesaver. When I got the diagnosis, I didn't know how to eat. When my doctor referred me to you, it was a godsend. So as a clinician, utilizing Epicured to help them feel better while minimizing extra work in the kitchen offers a nice solution for many of your patients. So, and you can get going on uploading your slide deck while I do a brief introduction. Ann Lee is well known in the dietetics community as really just an expert in the area of celiac disease. She is an assistant professor of nutritional medicine in the Department of Medicine and the Institute for Human Nutrition at Columbia University, and she is the dietitian for their Celiac Disease Center. Ann is involved in patient care and research. Her research has resulted in numerous published articles on the effect of the gluten-free diet on the quality the effect of the gluten-free diet on the quality of life, the nutritional adequacy of the gluten-free diet, as well as the economic impact of a gluten-free diet. Additionally, she has looked at the cross-contamination of inherently gluten-free grains. She has authored chapters on celiac disease and co-authored a number of chapters in GI-related journals and texts. She is also a member of the Academy's Gluten Intolerance Work Group, who's developed the Gluten Intolerance Toolkit and their Certificate of Training for Gluten-Related Disorders. She completed her doctorate in nutrition education at the Teachers College of Columbia University. Her dissertation topic was the impact of social support networks on quality of life in individuals with celiac disease. And so we'll help her get her deck up.
No, yeah. I will get it here. I think I now have it where I had two of them opened and that was where it just wouldn't start. Here we go.
Okay. And just a quick reminder before Ann gets started, we'll have some time for questions and answers at the end. We'll also send the recording and access to the certificate on completion of tonight's webinar.
Okay, I apologize. I have to get it to the, there we go. Okay, now we're set. Okay, well, thank you for that lovely introduction and for this opportunity to actually present with Epicured, because as the different testimonials have said, they really are a meal service that's a lifesaver for many of our patients on restricted diets. But what we're going to talk about today is that group of patients that need specifically a gluten-free diet for celiac disease. In particular is where our research has focused, but also for those on with non-celiac gluten sensitivity. And I think in light of the current situation, it came to me that, you know, our patients have a lot of concerns normally, but we really need to look at and address some of their concerns in this day and age. So we'll begin our journey. What we're going to talk about today is a little bit of background, some of the guidelines for care in celiac disease, some of the recent research we've done on the reality of what actually is happening in terms of follow-up. We're going to talk about the concerns of the gluten-free diet, both the usual concerns that we have on nutrition and cost, but then also what the current environment has done to those concerns. We're going to talk about the state of telehealth, both points for your patients and for yourself, and then some solutions and recommendations. So if you all are ready, we'll get going. Okay, our learning objectives are to identify methods that practitioners can provide, resources, and to discuss food safety and security. Okay, we're going to start with guidelines. And I think that this is important. I know we're going to take a step back and talk about the usual situation, the kind of the then time, because I think it's important to remember what the current guidelines are for treatment of individuals with celiac disease. The ESPGHAN guidelines, which is the Pediatric European Society, actually now says that their diagnostic criteria requires just a elevated TTG, the tissue transglutaminase, 10 times normal. A biopsy is no longer required for that diagnosis. Interestingly with this though, that was their new establishment, that was their update, but they did not include any directions or guidelines for follow-up care, specifically with a nutritionist or dietitian. NASPGHAN, which is the North American Pediatric Society, their diagnostic criteria is that it's a combination of both antibodies and biopsy. At this point, they have not adopted the SPGHAN guidelines. They do recommend access to a dietitian, and that is to ensure dietary adherence, which I thought was an interesting caveat. That was their focus. The British Society of Gastroenterology, their guidelines are a little bit older, back in 2014, and they recommend follow-up with an RD if adherence is questionable. Again, that recommendation for follow-up is really based on dietary adherence. The American College of Gastroenterology states firmly that there should be referral to a knowledgeable RD and annual testing for micronutrients. So you can see there's really a mixed bag of what are the recommendations for our patients with celiac disease. And why we bring this up is because when we look at what's actually happening, it almost makes the guidelines look good. One of the studies that was recently done by Herman and her group in 2012 actually looked at a patient medical record review, and they looked at 122 patients that had biopsy confirmed celiac disease between 96 and 2006. And what they did is measured the frequency of follow-up at the gastrointestinal clinic. And what they found that in 1 year, 41% of the patients followed up. In the course of 5 years, 88%, almost 89% of them followed up. But where it gets interesting is that when they were assessed for the dietary adherence, the numbers dropped. But even more interesting was how many of those were actually followed by an RD for that assessment. And you can see that over 5 years, it was barely 16%, which is incredibly low when we think about what those guideline recommendations are. We, based on that, we kind of said, well, we're at a celiac center, how are we doing? How do we measure up? And so we actually looked at 40 medical records of patients that were diagnosed within a 12-month period with biopsy-proven newly diagnosed celiac. And these were the patients that saw both the doctor and the dietitian. And what was interesting is that from that initial visit, when we looked at over that 12-month period, 32% had no additional follow-up from that initial visit. Only 12.5% had 2 additional visits over the course of the 12 months, which is what the NIH actually recommended when they developed their guidelines back in 2004. So what we see too is that when we look at those that did follow up, that it was interesting to see what happened with their lab data. And it really shows us how important that dietetic follow-up is. The ones that had initial blood work, you can see that, folate was normal, but D was low, ferritin was low, B12 was high and low. It was a mixed bag. But those that came back and saw the RD and had follow-up blood work, we can see that many of them had normalization of those micronutrient levels. And that really highlights why it's so important for RD follow-up. Now I'm saying this, but I know I'm preaching to the choir, but I just want to set the stage when we look at the current reality and what's happening going forward. We also know that besides this lack of follow-up, there is this ongoing burden of the disease. And this has been well documented. This is a chart used with permission by Dan Leffler, where he really looked at the burden of celiac disease compared to others. And you can see that where celiac disease is on one side of that scale, IBS and IBD are on the other, not far behind celiac disease. But most important is the impact of celiac disease and the gluten-free diet is multifaceted. And this was a slide I had used a few months ago at our conference, really detailing all the different aspects that our patients bring to us when they talk about the burden of this disease. But what I want to highlight is, in light of the current situation with COVID, what has changed. And some of this actually gets exacerbated. The cost of food has gone up. the chance gluten exposure is a real concern. Access to those gluten-free foods, fear of travel. There's so many things that have now become even larger burdensome that we need to be very cognizant of this as we're taking care of our patients in this time. Some of those things we're going to look at. We're going to look at a couple of the different studies that have highlighted some of these burdens. And again, looking at them from both the lens of then and the lens of now. There's been 3 major studies on the economic burden of the gluten-free diet. One we did at our center where we actually did a retrospective study. We had done a study back in 2009, and we did a follow-up in 2016 to see what had changed over time. And what we found is that the gluten-free products remained much more expensive, 183% more expensive than their wheat-based counterparts. What was interesting, the study that was done in the UK, is that even there the products were more expensive, less so than what we found in our study or in the study that I'll talk about next on Canada. But we have to keep in mind that the products in the UK at the time of the study were still all on prescription. So that even though their prescription covered the majority of their gluten-free needs, it did not cover all of it, and those foods are very expensive. The other thing the study highlighted in the UK was the lack of availability, especially as you left the major metro areas. The study in Canada looked at 2 large grocery chains, their 2 biggest stores up there, and did a price comparison. And what they found is that indeed there the cost was well over 200% more expensive. Why this is important is that when that was kind of when we look at what's happened in the market now, it highlights some of these shifts. In the study we did in 2016, the largest product availability was in the specialty markets. It was not as it was in the previous studies and in the Canadian study and in the UK study where everything was available online. We've actually found that there's a big shift where there are some things available in the regular grocery store, but the vast majority still are available in that upscale or specialty store, which is important at this point because access to those stores now are more limited. The other thing that we found is that the number of products within the subcategories of bread, cereal, snack items has changed dramatically. There have been a big increase in the number of what we would call mass market products. So things from our major wheat-based realtors, providers. But what we've found is that while there are more of those mass market products, what we've seen shrink is the variety of those products, so that where there may be 10 different varieties of Rice Chex cereal, there are now fewer actual brands of cereal on the shelf, so that we're seeing a decrease in the availability of items while we see an increase in the subcategories of those items. So why this is so important at this point in time is that the staple products have been the ones that increase in price, those things that are the breads, the snack items that the kids all want. But we've also seen a decrease of availability across broad spectrums. The other thing that we've seen, and we want to put this in light, is we've spoken about numerous times the nutritional concerns of the gluten-free diet. And one of the things that we realize is that the cost of gluten-free food may be affecting more than the budget. And when we look at when people are making decisions on what food to buy, that cost does come into the equation. And what we're finding is that that actually affects the nutritional quality of the diet too. We did a study where we looked at foods by the NOVA classification, which is the classification of unprocessed or minimally processed foods, which would be a whole grain or a whole grain flour, through the spectrum to ultra processed, which would be your bars, your breads, your cereals, and your pastas. And what we found is that the vast majority of people, while they did report eating one of the alternative grains, so quinoa, brown rice, oatmeal, teff, sorghum, these kind of things, we found that almost all of those grains were consumed in an ultra-processed form. Only 43% of those were consumed in an unprocessed or minimally processed form, and that food was rice and oatmeal. Everything else was consumed in that ultra-processed form. And one of the reasons people often mentioned that was that they could find it at the big box stores and it was cheaper in that very processed form. And what this does when we look at these grains and what people are eating, we find the largest area when we compare those that are eating, and this is from an Italian study that looked at the foods consumed compared to the general population, like our NHANES study. And what we found is that the individuals following a gluten-free diet tended to eat far more cereals and far more cake than the regular wheat eating population. And why this is important at this point in time, when we look at times of stress and times of increased emotional anxiety, we find that people tend to look for foods that offer comfort, reliability or safety, availability, and they're looking at cost. And we find that we're tending to see more people eat foods that offer the comfort, not necessarily the nutrition that they need. When we look at some of these other concerns, and when we kind of even dive deeper than just the grains and whether they're processed or not processed, we're finding that studies have done looking at the gluten-free diet retrospectively through food diaries, that very commonly we find that there are reduced levels of our micronutrients, and we see increased rates of obesity. The study I wanted to highlight was one by Valletta, who looked at pediatric patients, and many of the other studies that looked at increased weight over time on the gluten-free diet were done in adults. And this was one of the first ones that actually mentioned and reported that the number of pediatric patients on a gluten-free diet that were overweight doubled within the first 12 months on that diet. And when we look at the current rates of obesity in our pediatric population generally, this is really quite alarming. And especially when we look at their pediatric patients' food diaries, we find that there is that very heavy usage of those processed low-cost items and snack items. So this just raises more concerns about the gluten-free diet. So we need to look at the impact of treatment kind of a then and a now. And we've always noted that, eating is very much a social engagement. But that was one of the things that was most commonly cited as being a major burden of the diet, where people would say they were afraid to eat out because of cross-contamination. They felt limited in eating. In the study when we did it, it was talking about with coworkers, but as we've all kind of shifted our gears and have shifted maybe our living environments to being either at home, going back to family, living with an aunt or something, that changes. It may not be coworkers, but you're now trying to navigate a gluten-free diet in a different environment. Spontaneity is something that also came up in a then, and it has an impact for now, because we are all limited in what we can do and what we can order in. But one of the common things that families still can get is often to do, a pizza delivery does work even within COVID-19. But that's something that would be a real risk for those on a gluten-free diet. There's the concern of availability and the concern of safety and chance exposure. So where does that bring us? Well, in highlighting some of those burdens and the treatment now and then, we're going to talk about a couple other studies that we did that really look at not just the concerns of the diet, but the impact of the diet on our behaviors and our eating patterns. And there was one study that we did that we have called the Hypervision Study, where we looked at a cross-section of 80 participants, both adults and teenagers, and we looked at the quality of life scores, and we also did a vigilance scale. And what the vigilance was characterized by was a scale of 1 to 6, and those that were extremely vigilant were those that would only use a celiac-friendly restaurant, would ask thorough questions when dining out, has eliminated cross-contamination potential to their greatest degree at home. And what we found is that concern of cross-contamination was very high in both the adults and teens, and those people that were classified as extremely vigilant even those that were considered less vigilant. So when we look across the adults, 70% of the participants were extremely concerned about cross contact, whether or not they fell into the vigilant or non-vigilant category. Why this is an alarming number in this state of time is that we have less control now over that chance exposure when we're dealing with food preparation, either in someone else's home or if you're able to order something in. So that the impact and that concern about cross contact or chance exposure is very great. This study led us to look at well, what makes people more, hypervigilant versus less vigilant. So we looked at our teen data and again did the quality of life. We did a dietary adherence, and we wanted to see how would we classify the teens' eating patterns. And we were able to divide the participants into 4 groups. There was those that had adaptive behaviors or mostly maladaptive behaviors. And the maladaptive behaviors were those that had greater rigidity. They avoided either eating out or avoided certain foods. They had very controlling behaviors, and they were very preoccupied with maintaining their diet, compared to those that were adaptive, where they had greater flexibility, trust, and confidence. And why this is important is that when we look at these teens, over 50% of them actually were classified as maladaptive. Interesting, and the note for this time of COVID is that when we consider what our shopping and dining options are, we have limited shopping options. If you can go in person, there may not be food available on the shelves. If it's going to be delivered, do you always get what you've placed on that order? I mean, there could be substitutes in your Instacart list. If you're preparing food at home, are you able to do it yourself? Are you now in a mixed kitchen where you weren't before? Are you back with family that may or may not understand your dietary needs? And how do you check if you have the ability to order something in from curbside takeout or one of those? Now, how do you adapt to ask those questions of preparation? So the concern is that where our patients, over 50% of them, had maladaptive eating patterns before, in this time and under these circumstances with being quarantined, are we heightening some of these behaviors? And it's a big concern. And one thing we need to understand too is that there is a huge ripple effect. And when we did this study, we were looking at what the diagnosis did to a family. But I want to look at this again kind of in a new light. And now that we're home more, are there deeper ripples? Are there more ripples? Are there more effect on the family unit or the unit that you're now, sequestered with? And how does that now affect, how does that interplay with the burden of the disease, and or does that create more maladaptive or vigilant behaviors? And so these are all things that when we're talking to our patients, we need to keep these in mind, because they may not be something on the surface, but it may be deeper that we need to look at. And I'm going to highlight just a couple, I'm going to go through these very quick. Some of the studies that were done on quality of life. And what I wanted to show here was that, a lot of the studies early on were done here in the US or over in Europe. But when we look at more and more of these studies, we're finding that, from the study that was done by Deepak and the group in India, that their quality of life actually decreased after 6 months on the gluten-free diet. And the major burden was availability and cost and the cultural and family impact. Our study that was done several years ago, it was that social domain. And when we think of eating, even though we're now quarantined, eating in a meal is still social. And how much does that, impact of that diet, availability of food, concerns across contact, affect that social environment? And the study from the UK that was a 10-year follow-up, their major concern, and this is before COVID-19, was a decrease of availability of gluten-free food. And I think that that's even more of a concern in this day, at this time. So we look at treatment now and then. And I think that we have to kind of say, okay, the concerns we had before COVID were increased weight, nutritional adequacy, deficiencies, the cost, social and emotional. But when we think of it in terms of COVID and now, these are even bigger concerns, and especially those psychosocial concerns have become even more important. So when we think of celiac disease and eating, we really have to think about how tangled it is in the social web. And I have the picture of the kids making a batter of some sort. And all I could think of was those strings of the batter are like the strings that intertwine eating and our social nature. And so I think we need to really think about that at this time of increased isolation, obtaining safe food, availability of safe food, and food security increase the burden of the gluten-free diet for our patients. And we need to really be very aware of that and think about that when we're talking to them about, what's entailed in the gluten-free diet, avoiding chance exposure, meal preparation. We need to ask more questions to really dig in deep. A study that we did several years ago on social support and quality of life really looked at the types of social support that were associated with increased quality of life. And what we found in this study was that those participants that were part of a face-to-face social support network had significantly increased quality of life compared to those that used social support networks that were mostly online. What was interesting in this study is that we found that those participants that used online social support predominantly, but had a few or chance face-to-face exposures, those few or chance face-to-face exposures actually diminish the negative impact of the online support network. Why that's important is that as we're all kind of hunkered down in our homes and trying to navigate Zoom meetings and work, we need to make sure that we're aware of for our patients that increased isolation and the increased use of online meetings and things may have a very negative impact on quality of life. And that highlights that importance of some interpersonal communication. The study that was done out of the UK this year was one that looked at the hospital anxiety and depression scale. And they looked at those patients that were seen in a group setting compared to those that were seen individually. And they found that the anxiety and depression scale was significantly lower for those that actually had that face-to-face contact with their healthcare provider. And that was important because before COVID, there was so much discussion about moving medicine to telehealth and group classes and online classes. And I think a lot of these studies and what we're finding is highlighting that there is some efficacy in moving to these online groups and things, but there's also a downside to them. So it's a mixed bag. So when we look at the impact of COVID specifically on our patients, we are in the midst of doing a study on eating behaviors, a follow-up to the maladaptive study. And we were interviewing our patients with their 24-hour recall. So we asked them, what has been your impact? What has been, the biggest thing since being quarantined? What is that impact of COVID on your diet? And you can see some of it is very positive and some of it is a little bit more on the negative side. One of the participants said that, she never would have thought of it, but cooking by herself and being at home, she is much more compliant than she ever was before because there's less chance of exposure or eating the wrong thing. Another one said that they're doing exactly what we had talked about with those comfort foods. They're really eating less healthy and eating a lot more comfort foods. Their life is much less structured, so it's like eating on a weekend all week long. Another participant moved to her aunt's house where now all the meals are cooked and there's variety, but there's also navigating people who aren't used to preparing gluten-free foods. Some of the other responses we have had were that there's a lot more snacking. They don't have to pack lunches. People find that they're can't find their gluten-free foods. They've had to rely on a few staples. We had one participant that said she's not eating as many fruits and vegetables every day because she doesn't want to have to go to the market or try to shop. So that we're seeing, a large variety of impact on our food procurement and our food preparation. We also, in looking at this, looked at our own, as we started our telehealth nutrition visits, I thought, well, we ought to look and see what is it that people are enjoying about this? What are their concerns? What are their preferences? And so over the past 2 months, we've been actually collecting data very informally from our patients and just saying, okay, let's look at our patients and really see what their likes and preferences and barriers are. And what we found is that the new patients are actually very excited because they can get in to see us much more quickly than they could before. They also feel that, and this is according to this time, that they don't have to travel to the city. So they feel that very much it's much safer. A lot of our follow-ups, I've had several patients say that they were so happy to see my face on the video conference. And they're very grateful for the continuity of care in these uncertain times. And when we look at the data in terms of by ages, the preferences of face-to-face versus telehealth, one thing is very important is that generally people would, no matter the age range, would generally prefer the telehealth. In that over 50 group, it's a little bit more split. But when we break it down into those new patients and the follow-up patients, what we find is that telehealth really is something that patients are looking for. A lot of our follow-ups would say, instead of coming in every few months to see you and to check and make sure that we're doing the appropriate guidance on the diet, if we could do an in-person, once or twice a year and do the other visits by telehealth, this is their preference. And it's what the question I have to bring up to all of us is that, is this skewed by the current time, or is it just really a matter of convenience and efficacy? Some of the other things that we found in terms of pros and cons, our patients said it's easy access, it's flexible, they're able to check, we're able to check labels and products with our patients. There's a lot we can do because we're in their home in a way. Some of the downside is that, it is isolation. There are distractions. Jessica and I have talked about this, where we've had a couple, either FaceTime or Zoom meetings with patients where kids are fighting in the background, or someone comes in and gets interrupted for a work call, so that there are definite issues. As a practitioner, it's hard to show someone the Bristol stool chart through the video. It's also connectivity and technical issues can be a problem. And one other thing that has come up is really the accessibility to computer and to telehealth is not universal. There is very much areas where it is limited. What's important is that when we look at these visits that we've done telehealth, only 13% were by phone with no video, all the others were video. And I think that that's an important aspect when we reflect back on that study with the social support, is at that time, the online was more strictly online, not as much video. So that may make a difference. So are there solutions? And this is where we need to come to and really figure out what we can do to make things better. When we look at that social support study and we look at social support, that is something we have found is crucial to adherence to the dietary regime, especially for gluten-free, that if you feel you have support, it's easier to do it. We found in that study that there were 4 main social support groups or forms of social support that really had a significant positive impact on dietary adherence and quality of life. And that was the accommodation by family and friends. It was school and community, it was a group support, and that others in an individual circle were on a gluten-free diet. Now, what I want to highlight, where those are the 4 main areas, what's important is that when we look at family and friends, it was that family and friends were encouraged FaceTime or video chats or something so they felt connected even during these times. For the school and community support, when we look at what's being offered now, many local churches and community groups have started offering virtual or video lectures, coffees, museum tours, and I have some links on some of these things for you at the end. For group support, you can have a group even in these times of quarantine, and it's important that our patients learn to find their tribe. The same group will not work for everyone, and I think it's very important that we encourage people to really find their circle of support. And that others on the gluten-free diet, I encourage my patients all the time to have virtual dinner parties, happy hours, have a coffee with a friend, take your phone and do a chat as you go for a walk, but just something that you can feel that face-to-face, because that face-to-face is connection is what we find has that very significant impact on quality of life and lessening of burden. So that what we find is that face-to-face, even by video, gives us a sense of belonging, of being understood, and safety. So the road forward, when we think of what our usual counseling sessions are, we have to think about our assessment, our education, and everything that we usually do day to day. And I can't say it enough that we need to now think about our counseling in a different light. We need to think about counseling beyond diet and nutrients. We have to cover the patient from cell to psyche. We need to have them accept the situation, find their inner adaptability, and help our patients to identify both their barriers and their support systems, and to really find new ways to stay in touch and to find things that will provide them that security. In the challenge to dietitians, I think that when we think about our basics, our assessment must be multifaceted, but we may have to be creative now because we may not all have access to a chart. It may be more challenging to get a medical history and lab data. Be creative, ask the patients. We also need to assess the patient's food environment. And that's something that now that may actually be easier to do, because you could ask for a virtual tour of the kitchen, look at products in their cupboard, look inside the refrigerator, see what we can do to help guide them, help them navigate through a label, help them navigate through the ingredients, because you have a tool that's right there in their kitchen that they can use. One thing I would say is that with these new challenges, we will need to be even more aware of how is their living situation changed. Who is preparing in that everyday participation of meal preparation? Is it different than usual? Are you in a different situation? Is the kitchen now shared where it wasn't before? Grocery shopping is a whole new challenge. And I think we need to highlight or to really think about the financial limitations that may be on some of our patients at this point in time. When we think of our assessment, again, I can't emphasize enough, it's got to be multifaceted. And to be honest, that diagnostics may have to wait, and we may have to just work with what we have available. When we look at assessment of knowledge, beliefs, and attitudes, I think it's very important that this is an area where we need to even spend some more time. We need to be able to really try to assess the individual's knowledge of the diet. Are they understanding the limitations of foods allowed and foods not allowed? But then we also need to look at relief in real life. They may have relief that they finally have a diagnosis and they're preparing their own foods and things, but the real life situation is too, they need to be vigilant. They need to, access foods. They need to change meals according to social situations. There may be limited availability. We have patients that have never cooked before. That may be a burden as well. So we need to really look at their knowledge, their beliefs, and their attitude surrounding food, meal preparation, and the diet itself. You also need to really focus on the psychosocial impact. And it's so important in this circumstance to really look at patient behaviors. Are they avoiding food? Are they limiting their intake due to food security, or making things last, or cutting cost, or just being worried about contamination? Are they avoiding unknown food because it's not a familiar product to them? It's a new grain. They can't get the things they're usually used to. And what are these emotional issues? How is it affecting their quality of life? Are they experiencing, more fear of gluten exposure? Do they feel like they're a bother in the home? Are they frustrated with family that doesn't understand them? And so we really need to make sure that even if we've seen this patient before and we're seeing them in follow-up, to really assess what the changes have been that they've undergone. So what can we offer? We as experts need to expand our counseling skills. We need to talk about stress reduction, mindfulness. We need to encourage activity even with being, quarantined at home. We need to think about creatively in food availability and preparation. What can you make with 4 ingredients in your kitchen? What can you cook when you don't cook? We need to put these hats on so we can help our patients navigate these things. And I think that that's very important. And this also highlights, going back to the beginning of our presentation, the importance for follow-up. These are times when our patients may need to talk to us more frequently because they're undergoing different situations and different issues may come up. Resources, there's some great online sources to find out where you can get groceries delivered. Food pantries, there's been several articles in the news just recently where several of the gluten-free food manufacturers have donated hundreds of thousands of dollars worth of products to food pantries nationwide. There's meal services like Epicure. There's healthcare where there's offered telehealth visits with both MDs and RDs. There's support groups that are both national and local. Celiac UK, interestingly, has a hotline when you've got questions or concerns about the gluten-free diet that you can just call and they connect you to one of their support group leaders. But there's also things that we can encourage our patients to do virtually. There's a great, from the YMCA, free fitness workouts and exercise routines. Museums, internationally are doing virtual tours. So there's many things that we can help our patients beyond just the diet, because we have to help them emotionally to deal with this as well. Some of the other resources for clinical practice, there's FaceTime, there's Zoom, there's What's Up, there's Fruit Street, there's Healthy. What's important is you have to find what's comfortable for you. I have to say that coming into this, I am not a techie, and I was concerned about being able to do telehealth with my patients. And I'm finding that over time, there is an adaptability that I've developed. But I've learned that I've been able to incorporate my counseling skills into this new technology. That just because we're doing things technically and by video and telehealth doesn't mean that you can't remain a good counselor. So food for thought, what do we need? And I think that this is important because while we've talked about what our patients need and what we need to give to our patients, I think we also have to be mindful of what we need. One of the things I've missed most about remote telehealth is that quick conversation in the hallway with our colleagues in between patients, that feeling of connection and being on a team for your patient. But the other thing that we need to be careful is we need to protect our time. Telehealth is available 24/7, and I've had patients ask if they could do a call at 9 o'clock at night. And we have to mean that just because telehealth is available 24/7 doesn't mean that you are always working, and you need to set up those boundaries and protect your time. Because just like our patients are, living through unusually stressful times, so are you. And although your home office is where we're all working from, we need to remember that your home has to be your home and your office. It doesn't necessarily get too blended. So key takeaways, because I know we're just about on time, is that when we look at that clinical aspect, I think we have to really be creative in making sure that we're doing a good assessment. We're really getting at eating behaviors, use of unregulated supplements? Do our patients need referrals for psychological or emotional therapy? And just to remember that it's not diet alone, that we must incorporate both the physical and emotional aspects for our patients. We need to encourage them to be connected. We need to encourage them to practice mindfulness activities. We need to make sure that they're engaging in routine physical activity, not just from a weight and health perspective, but also from a stress reduction and a psychological perspective. Now more than ever, we need to blend that art and science of nutrition. We need to adapt our methods of practice to a changing world. Our counseling skills need to be honed in a different way in this new setting. And we need to listen and observe our patients. We don't get to see them face to face, but we can still listen and observe. We have to recognize this may be the new normal. And how can we adapt, expand, grow ourselves and our practices? And how can we best serve our patients and clients? So to our new future, I encourage you to be creative, to be inspired, and thank you, and be safe.
Thank you so much, Anne. You're such a gem in the dietetics community. That was so perfect. And, I think we're all under duress right now living in a pandemic. And certainly when you're navigating not feeling well and trying to manage GI symptoms, it certainly can offer up, or just the burdens of living with a chronic illness, potential, all the various effects adds an extra layer. We do have a couple questions. So our friend Nikki Streley is listening in. And one of her questions was, a lot of patients, and I've seen this in my practice too with celiac disease, might come in 1 or 2 times, feel like they really have a sense of the diet and go on their merry way. They might not have a physician that's reminding them to come back. So, as a solo practitioner, do you have any recommendations to someone that's in private practice as far as keeping the individual with celiac disease engaged in their RD care?
I think one of the things that we have to stress is that just like you see your physician every year, you should see your dietitian at least every year. Once, if you feel like you've got a handle on the diet, that doesn't mean that you don't change over time, that your eating behaviors can't change over time. And so I would really encourage them to think about their nutrition care just like they would their general physician care, that we need to change and adapt as they age and as they grow. And it's important to stay on top of those micronutrients, the weight, and as we go through our different life stages, that our social, emotional, psychological needs will change too. And a lot of those center around food, and that would be something that a dietitian can guide them on.
Absolutely. And I know, in my practice, I would kind of set that up too. You can set that up as the dietitian saying, let's just plan a 6-month year visit and just try to schedule out even a few appointments out at that first initial visit. That sometimes can set that stage for that as well.
Kate, you're so right. I think that brings up a very important point. I find that if you don't set something up either, at the close of your initial visit saying, okay, let's plan for, kind of develop a roadmap with them. They may not see the importance, but if you take the time within your initial visit and say, these are, this is what we covered today, kind of a recap, but this is what we have to cover going forward, that then it gives them an idea and an expectation of the future that they'll have, with you.
Right. Yep. I like it. So another question is, it is my understanding that telehealth is only temporarily covered by insurance through the duration of the pandemic. Are you aware of any lobbying activities aimed at keeping it covered or any update on that?
That is a huge question. Right now, it's covered temporarily. There is a big concern amongst the physicians as well as many private practices and dietitians, whether that coverage will continue. There are lobbying groups. I believe the American Medical Association is in there, and a few others, to try to push for the continuation of funding for and coverage for telehealth. But right now it's very unsure. It's very unsure.
Yeah. I think, you know, talking to other practitioners, the sort of feedback is the train's left the station. Patients are really liking it. A lot of practitioners are really liking it.
Mm-hmm.
You know, I hope that collectively their message gets to the right people. And, you know, I just think of just sick visits, and to minimize exposure for some of these visits could really be helpful, right? You know, you go to a doctor's office and you're exposed to a variety of other potential illnesses.
You're exposed to a variety of things before COVID. And so increased risk now. And I think that was part of the reason to collect data and to really assess what the current situation is. Because I think that when we have that data that's evidence-based, that this is the benefits, yes, these are the barriers, but these are the patient preferences. And if we can increase patient compliance with visits, that has to, in the long run, decrease that overall insurance cost. And I think that that may be a way we need to approach it with the insurance companies to make sure they understand.
Yes, so please do that for us. No.
I'll keep collecting data.
Exactly, you're our data queen. Okay, another question. Can you please comment on the new FDA labeling rule allowing for temporary ingredient substitutions without label changes? Have you heard about this?
I have not, but that sounds very scary, because that would be something that would absolutely be very worrisome for our patients on restrictive diets, you know, across the gamut, where if they can do temporary substitutions without changing the label, that's a concern.
Yes. So I did see a little bit of it, but I don't know. I mean, they still have to stick to gluten-free, or, you know, if it is containing wheat, you know, or an allergen, have that listed. But I do know some companies are better at, you know, the gluten-free, you know, I don't know if they're allowing purity protocol oats and substituting just oats. Like, you know, what are they doing that's going to be okay?
That would be a real concern. And although I've heard a little bit about it, I would say the person who probably would be the expert on this would be Trisha Thompson at Watchdog.
Yeah.
That's glutenfreewatchdog.com. And has an ear to the USDA and the FDA, and really, she's great with having the current things that are going on there. She would be my resource for that.
Right. And she is active on Twitter as well, so you can reach her there. She's got a fabulous website and her work is phenomenal. But I believe her handle on Twitter, gluten-free, let me just make sure. Yeah, it's at GF Watchdog. So she shortens it, but it's Gluten-Free Watchdog. Trisha Thompson, she's another rock star like Anne in the celiac realm. I loved, we were out of questions. I just wanted to really put a shout out for just all the psychosocial and the importance of mindfulness and exercise, and so much of just treating people's total health, not just a lab or a diagnosis, you know, or their body, but the connection of the body and the mind, and really looking at people in that way, certainly during a pandemic, but just always, right?
I've always felt that, you know, we're treating a person, not a diagnosis. And that's an important aspect to remember. And I think it's highlighted at this point in time. And maybe that was the motivating factor for where my research has taken me. But I really think that we can't forget the person behind that diagnosis. The more we understand and can reach them and help them with the mindfulness, with the activity, the emotional, the psychosocial emotional aspects of it, the more likely we're going to be successful with that person.
Absolutely.
Compliance.
You know, and just the whole, when you think of someone being so hypervigilant with their diet and their quality of life is so impacted by that. And it's like on a mission to improve their health, but they're not really improving their total health because they've added this extra layer of perfection and stress. And again, we've got to be looking at what their decisions are. Maybe their celiac labs, serology, everything's perfect, but
their life is miserable.
Right.
Right. So, and I think that that's an important takeaway for any time. But I think with the increased emotional burdens now, even more so now.
Absolutely. I agree. Well, this was fantastic. No surprise.
Thank you so much.
Thank you so much for coming on. And we're just at 7:01. So you were really on top of it with your slide presentation, and we're done with questions. So have a wonderful evening.
You too, and be safe. Thank you.
Thank you.
Thanks, everyone. For those who are leaving, no problem. I just wonder if any of you can hear the sounds in the background from New York, where it's 7 p.m. and every day at 7 p.m. people cheer, bang pots and pans, and clap for all of you clinicians who are doing incredible work at a very difficult time. And so I don't know if you can hear it there, but it's probably too faint in the background, but there are people here cheering with gratitude for all of you. And I want to express that to all of you too. So thank you so much, and have a wonderful rest of your day.
Bye-bye.
Bye-bye.
Bye.